Thank you, and thank you all for your really important comments. You know, as I was listening, it reminded me of my initial foray into the world of community pediatrics, and I went to a training session and heard someone told a story about how there was a group that had some money and they were interested in building a health clinic, and they went to a community in rural Brazil to offer to build them a health clinic, and the people there said, you know, what we really need is a soccer field, you know. And so they said, well, you know, we want to build you a health clinic, and they said, well, you know, we want a soccer field, and so ultimately they built the soccer field, you know, instead of the electronic photo screening, right? And so then they went back and said, would you like a health clinic? And he said, no, we want lights on the soccer field. But then the next time around, they went and they said, well, what would you like now? And they said, we'd like a health clinic. Can you build us a health clinic? You know, and so we heard, I think, about the importance of building relationships and the importance of also understanding who you're serving, you know, and what the needs are of the individuals and the population that you're serving. And one of the things that seems to be often the case is that well-intentioned people have good ideas, but those ideas aren't what's needed. And I think we heard some of that here today, you know. And so the first step that we have to do in building those relationships is say, you know, what are the challenges that you face and how could we potentially work together? And, you know, we have examples of working across sectors here today. And I guess one of the things that I would like to hear from folks is, so what would it take to really open those lines of communication to allow the types of conversations that really need to happen to put, you know, to deepen and broaden the foundation for success for the kids in birth to 8. Does anybody want to try to answer that?
I would. One idea is, and this kind of came to mind during the introductions, is that the first meetings, collaboration has to start before the money comes. So, and that's sort of, if you think about the grant world, we talked a little bit, Melinda, about folks coming to you with things that are sort of prepackaged, ready to go. Here's this grant, can we do it here? Our model is a community-based participatory research model, so we don't get the money before we know what the community needs. So that instead, a true collaboration is not creating something and then finding a place where you can try it out. It's thinking of what needs this, what community are you trying to serve, and finding out, these are our strengths, how can our strengths work with your strengths, and to create something that's going to make things better for the community and that's sustainable. And then I think if the earlier you have those conversations, and it's hard because we all have these great ideas and we want to put our ideas out there, but it takes a lot just to, before even making any plans, you've got to sit down with the partners and find out what each partner really wants and needs.
Great. Anyone else like to add to that?
Well, on an individual basis, just getting the problem with the communication between the schools and the healthcare providers is a challenge, and we've started to make inroads. We have like a diabetes resource nurse who consistently communicates with the physicians in the area, the endocrinologists, and we've just now started to have them have meetings to discuss how can we make this work better, how can our forms even be tweaked so it meets everybody's needs, how do we get one form that works for every endocrinology clinic in the county. But those are just really little baby steps, but at least I'm optimistic it's a start.
Okay.
I'll add to the fact that with homeless families, we often find that they tend to want to isolate themselves, like maybe at the shelter, they want to isolate what the shelter knows about them, and then maybe what the school knows about them. And I know at the school level, sometimes it's frustrating for the homeless liaisons maybe to have different details than the shelter does. And so I think it's really keying into building the relationship between your partners and understanding where the strengths, as Tamani said, about maybe where the relationship can be built first and foremost, and then building that trust and relationship to broaden the spectrum of linking them to other resources.
Good. Lisa, you have a comment?
Yeah, whenever I think of the communication issues and what we're asking all of us to do once we're out there working in the field, I think we started off incorrectly. And I'm blaming myself on this as a trainer of school psychologists. I mean, we train school psychologists and we don't reach across to the speech-language pathologists or the nurses or physician, whoever, and co-train like we should. And so I know it was an earlier panel discussion, but I think, I almost think we set this communication pattern up very early in the training process. And that's maybe then where we can find some solutions and some ways to help enhance communication across professionals, across resource agencies, so that the talking has begun early.
Gisela, you've got a one-stop shop, really, at Magnolia Place that Dr. Coker was talking about. Can you share at all about how that came about? What did it take to make that happen, where you were able to bring, or where someone was able to bring all those agencies together?
Well, I know that it was the dream from the nonprofit Children's Bureau. I don't have all of the information because I've been there for 1 year.
Yeah.
But, you know, we can definitely get that information for you.
Great.
Yeah.
That would be very helpful to us. Let's open it up to questions from the committee. Are there questions that folks would like to ask? Ross has a question. Stacy?
This is Ross Thompson, UC Davis. It seems to me that the pediatric healthcare system is absolutely crucial here, partly because they're often, as you pointed out, the professionals that have some of the earliest contact with families. They are sometimes, for families, especially in the early years of life, the only professionals that they're regularly in contact with, especially if they're in that risk circumstance. And they're also the professionals that are likely to have more extended contact compared to other agencies. And so I think that the work you're doing is really very important. I was surprised, however, that the one avenue for reform, and this may be part of the sort of the well-meaning but stupid ideas that people propose, is to go by the European model and ask, do you really need an MD to do the full examination? And if you brought paraprofessionals in the circumstance, would it be possible then to provide the additional screenings to do the family counseling? I mean, the question of, is this a mother who's depressed, has significant implications for the health status of her baby, and to be able to include more of that because you're not using the MD's time except on an intensive consultation basis, but you're doing it with, say, a nurse practitioner. Are you exploring that at all? Because that would seem to be a really desirable avenue of reform, or is that just a stupid idea?
No, that's how the rest of the world works. I'll start with that. Yeah, that is how the rest of the world works. You don't have pediatricians talking about toilet training and discipline and timeouts and so forth. Many developed nations have a completely different pediatric system where pediatricians are the specialist. There's no concept of like the general pediatric preventive care visit, because preventive care are done, and even not at a level of a nurse practitioner. I mean, at a level of RN or public health nurses are doing these preventive care things that we in this country pay pediatricians to do. So yes, that is, I think, the way that we would like to see things move towards. But we are a long way from that, because right now, in order for a pediatric preventive care visit to be reimbursed, a physician must touch the child. So, and one of the projects we're doing is group visits, and even the parent-coach visit model, what we've done is the parent-coach spends about 20 minutes with the parent, and then the pediatrician's time, which was usually about 15, has been cut to like 7, because they just come in, they see what they've already discussed with the parent-coach. If there's some red flags, they will reinforce whatever the referrals were, or they may make a decision about speech delay and such. They do the physical exam, and that's it. So we're able to, within the structure of our healthcare system, we're really able only to reduce the time, but in sort of the lead up to these kind of models that we've developed, we met with Medicaid, and at that time there was Healthy Families separately, and really looked at, well, what is it, what counts as a preventive care visit? And you must be touched by the physician or someone who has a license. So, but that's a great comment.
So you're saying the obstacle is managed care?
The obstacle is reimbursement. So who's going to get paid for the visit? So if we changed our, the obstacle is Medicaid. So if you think about publicly insured kids, which are sort of most of the bulk of, becoming the majority of kids in California at least, for a preventive care visit to be reimbursed, yes, they need to be as a physician visit. On top of that, for managed care is different because, managed care, you're getting amount of money, like a pot of money over per patient per month to take care of the child. But the difference is this little thing called HEDIS, which is a quality reporting. And so you get these managed care plans, which now most of Medicaid is going to managed care, so you're not getting paid per visit, but you're getting paid per patient to take care of them over the time. And if the HEDIS quality measures show that your kids aren't coming in for a well-child visit, and a well-child visit means you saw the physician, then your quality measures look bad, and then you don't get as many Medicaid patients that next cycle. So it's, that's a big barrier. Mm-hmm.
Lisa, you have a question?
Hi, Lisa Guernsey at New America in Washington, D.C. Thank you. This has been really helpful. I'm wondering if any of you can comment on either thinking back to your own experience in higher education as you were training for your positions now, or any subsequent interactions you've had with higher education where your field connects in some sort of structured way to the education school or the early childhood preparation programs, and if you felt that connection was deep enough or not.
Mine's easy, so I can answer it. In California, school nurses are 4-year bachelor prepared RNs, and then they have another 30 units postgraduate to be a school nurse, and that's really deep in understanding how the education system works. Of course, it could be improved, but we learn how special ed works, how the programs work. So for that's very easy, and of course, for school nurses who go on to get their administrative credential, then it's much deeper than I ever wanted it to be. So yeah.
And we make some efforts in that regard, and we do actually have some classes that are cross-training, so with social work or with counselors, teachers, and I have my students go out and work with the teachers in schools. That's just part of a school psychology training program. But what I see and what I'm hearing today, the missing piece is with the medical profession, as well as more time with the resources. We do get out to Head Starts or other early childhood type programs, but I really think it's the communication with the medical profession that we're lacking.
From sort of the medical training perspective, in pediatrics, I think it's very dependent on the program. But I remember in residency, we went to regional center, I think, for a day.
And for those who aren't from California, what's
Sorry.
that?
So services for children who have developmental delay or autism or some other developmental problem. They'll get assessed and receive services, and regional center is where in California they receive those services. So I think there's there was some real small time spent, but it's very, residency is very medical focused. There's some time spent in community clinics. As far as school goes, there's community rotations. You would spend some time in the school-based clinics, but again, there you're just with the provider, so you end up, seeing what kids in school need as far as medical goes. I think one thing that's really missing is a better understanding of the IEP process. I can't tell you how many times I have to use it or have asked families to use it. But I don't think I really started understanding what that process was about really until my kids started going to school, and just from other parents and the school that my children are at. So that process, boy, I think we could do like a month rotation in watching IEPs and how that works. The one area I think that is that most academic centers do well at is social work, because we have social work within our clinics, and so we are really good, I think, in working, at least at UCLA, with the social workers. But the schools, that's a tough one. It really is.
In regards to our department, we do have educational liaisons that will help. So they will review cases, and they will work together with the school when there are issues or any concerns going on. In regards to Magnolia Place, what we do help our parents is when we see that there's a need for an IEP, we will call the school, we'll help them write a letter and explaining the reasons why we're requesting an IEP. And what we do is follow up with the parents. If we feel that they're not, they need more services and they're not being listened, then we go, to LAUSD and ask for more assistance. Mm-hmm.
Do you feel like you were well prepared in your education to do that kind of work, Gisela?
I agree with you. We need more information on IEPs. I personally have learned more about IEPs because I have a child who's autistic, and to tell you the truth, that's how I learned, is really going through the ringer, and really just learning to self-advocate. I've been reading a lot of books. If, for example, Loyola Marymount has a Saturday training on parent, I'm there, but that's what's helped me to learn how to advocate for myself, and it's what helps me help others to learn how to advocate. And I wish there was a class, like a college course on IEP 101. Hopefully someone can start that up.
I'd be there with you, sitting right next to you in class.
Cresta, do you have something to add?
At our Child Development Center, at our shelter, 95% of our teachers either have their associate's degree or their bachelor's degree, so they have higher education. But when I started there, it was a whole different ballgame. I came and I thought, wow, I have such qualified teachers. And yet when it came to working with children that are experiencing that magnitude of trauma, it was not so much. It was a whole different ballgame. So, and I'm not saying that they hadn't taken courses on that, but it was really through a process we identified that we really needed to bring in a specialized trainer to teach us how do we work with children and their parents that are experiencing trauma, homelessness. How do we interact with them? What can even our expectations be? And then a big piece of that, quite honestly, was removing our judgments about them. And taking it back down to being focused on those early childhood education tools that we already had, of those intentional interactions and all of those other things we knew. We just needed to remove some of those barriers and then to come to a better place of understanding our families. So yes and no. semi helped us.
You know, while Janet's getting the microphone, I was just thinking, you know, one of the things that I hear that's a common thread across for all of you is that you're all connectors. You know, you're all connecting families with other resources. And so I wonder whether in that process, are there resources or professions or supports that are just missing, that you'd say, oh, if I just had access to, I could really help this family?
I'll say there's mental health often comes up, and it sounds kind of weird because everyone knows that there are mental health providers, but when it comes to children and, you know, publicly insured children, it's hard. So that's a place where I think, yeah, lots of times I go, oh, I wish I could get some services for this child that are, you know, it's not going to be long wait list or long drive because they don't have a car, those kinds of things. And then the other place is once they are over 3, I think someone said that earlier, but those mental health, but developmental and behavioral services for children who are over 3 who maybe don't have a diagnosis yet but still need services.
I would also agree with that. I think the mental health piece is so lacking in early childhood education and with those little ones. We have, as an illustration, we identified that we wanted to bring on a child therapist at our child development center, and it took the organization that we were contracting with a good 6 to 8 months to find somebody that was willing to step in and do that. And still we're continuing to identify that we have such a high need for that. She can't even take all the cases that we make the referrals for. So.
I see some other heads nodding. Do you have similar kind of experiences?
Adding to the mental health, another barrier is getting therapy and psychiatric care for families that don't have any insurance or families that are undocumented. A lot of our children that were not born in the U.S., mental health services are very, very limited, if not almost absent. And a lot of the times, the only time that they get service is when there's a crisis, when there's a suicidal ideation, homicidal, when there's a crisis and, you know, there's a psychiatric hold. And what happens when they're released from that hold? If the parents don't have the necessary means, the insurance, the financial ability to pay, because they're barely making it to pay the rent, how are they going to service that child? Yeah.
Okay.
One reason that I was so thrilled to get the invitation to come here is that school psychologists are often not given the invitation to be part of 0 to 8 services, or we're just minimally involved, maybe doing some testing or brought in at a time when things are extreme. And we are trained on mental health services and can apply those services to schools. And so I see that there's a missing piece there that could be enhanced, and I hope it is.
Okay. Melinda, anything you want to add?
Well, it just kind of goes along with that is when you see on rosters that there's a school psychologist, don't be fooled to think that that school psychologist is providing mental health services. Most likely what they are providing is special ed testing.
Right.
And we would much rather be doing the mental health services and lots fewer tests.
There you go. Jana?
Hi, Jana Fleming from Erickson Institute in Chicago. I have a question for Lisa, and it could be that part of my question's been answered by your focusing on mental health, but I would like also the rest of you to chime in. But Lisa, you gave a lot of really useful examples of services coordination going well, but you also mentioned this increase in expulsions at the preschool level. Can you say a bit about, from your perspective as a school psychologist, where the breakdown in the system is that's leading to these expulsions of pre-kindergartners? And I'd like the rest of you to speak to it as well if you have a perspective you want to share.
Well, I appreciate some of the comments made at the earlier panel that that discussed how we're asking our teachers to know a whole lot about everything. So it's a knowledge base that the teachers have to have, but also a skill base. And that's where, in terms of behavior, yeah, you can recognize a behavior problem, but the skill in dealing with it is very complicated for many of our young children. And so I think that putting all that on the teacher, I agree with the earlier panel that that's a lot to put on with teachers, and that's why I think more collaboration, more service, support service provision in those early childhood classrooms are going to be helpful in that. Because if, Hannah, I think you were mentioning, the number of children you have in a class, and if you have 15 children in a class and 2 are extreme behavior problems, or even 1, it's very hard to do your job. And so the option in early childhood is you can exclude them from services. You can't do that. Well, few exceptions at school age, but in early childhood you can. And so that has become an option for many who just don't have the ability or the skills to deal with the situation. So I know that our programs that focus on dealing with behavior problems, especially with preschoolers, those businesses are growing in our area. So day treatment programs, educational programs, I'm glad they're there, but it's a sad commentary on what's happening. So it's a skilled, yes, there's skills for teachers, but again, I want to stress that it's providing those supports, and enough of them, and they're not there.
I'll chime in on that. Having come to UMOM from a corporate preschool where our classroom ratios were what the state mandated, 4s and 5s, you'd have 1 teacher to 15 children. And in the school that I was at, we had a high percentage of children that were in foster care. And so hence had been experiencing trauma. It looked like they were fitted in a good home, but yet at the same time we didn't know the extent of their background, and so a lot of behavioral issues. And it really came down to the fact of, I wish I could have provided more teachers in that classroom to support that teacher, to have that one-on-one interaction. Where I'm at now, we self-limit our classrooms so that, a teacher can walk out with a child to de-escalate them, take them, out on the playground, take them just out of the oversensitized environment that they're in with the other 15 children in the classroom. So I really do think it comes down to the support in the classroom. And then also, I think something was said earlier about the administrators being there to support as well the teachers in the classroom and to guide them, so.
Can I make one more comment about, I do think this is critical, because one thing we know is that if we continue to let the behaviors occur after early childhood time, they're only going to get worse. And we also know that if we do address them early, they will get better, and that we won't have the long-term problems for that child, for that family, and for society. And so that, I do think this is a critical issue. So thank you.
Okay. Anyone else want to comment? I saw another question. If the committee doesn't have any more questions, I see one up there. Fabienne, I can.
Hi, thanks panel. I'm Fabienne Doucet from New York University. One of the ongoing themes today has been professional development, and I'm just curious about your thoughts on professional development for your own fields. Krista's comment made me think about it with you talking about judging families, and I was just thinking about how if one of the things that the physicians have talked about is that physicians oftentimes are the first point of contact for many families, and then they get to school. So if you if a pediatrician doesn't know how to deal with families that come from diverse settings and with different issues and so on, then you can easily see sort of that informing the kinds of things that would then happen subsequently. And so I'm just interested in this idea of like how the ball gets rolling from the beginning, and I'm just wondering how professional development might play into that, and just what your thoughts are on your own fields and how that takes place or doesn't.
I'll speak into that. My husband and I went through training for foster parenting, and I think one of the most impactful pieces of professional development, so to speak, in that realm was when we did a visual of walking in the shoes of a child coming to a home that had just been usurped from their birth mother, birth father, and at a stranger's door. And so that's also something that we've done with our teachers, of helping them to come to this place of this understanding, almost putting ourselves in the shoes of the child, of the family. And that's how we've really tried to decrease the layers of the judgment, and also coming to terms in the judgment of what are our own triggers. Oftentimes, I think when we're dealing with families that are the hardest to care for, is sometimes, and this is my own personal opinion, it's sometimes things in our own personal lives, our own triggers that maybe cause us to have that judgment. So that's not scientific, that's all Cresta speaking, but I just think that that's, for us, it's been a highly beneficial exercise, and I would recommend it for anybody in any field to do when you're working with families.
I think your question about getting the ball rolling and how professional development affects a pediatrician's ability to identify those kids so that they can be into services before school starts. I think one thing that's really moving forward in the field is that people are now understanding it's not enough to say, you know, I've been practicing pediatrics for 35 years, so I can identify a kid. I know when a kid is delayed. I know when a kid is autistic. We're really moving away from that now and focused on, did you do a standardized developmental screen on that child? What was the score? And based on the score, what do you do with that? And so that has been evaluated. Those are the kind of, there's surveillance, which is just, you know, when the child comes in and say, oh, you know, is Gabriel talking? How many words does he have? That's kind of just my gestalt of it, and I can kind of think what, you know, where they are developmentally. Or I can do that, and I can give them the ASQ. I can use the PEDS. There are standardized screens that we really should be using at, say, 9, 12, 15, or 18 months, or there's some combination. Usually there's 2 developmental screens before preschool and at least 1 autism screen before preschool. And I think the field is moving towards that so that there is some standardized way of finding those children who need services. Connecting them to services is a whole nother conversation, but if you don't make that assessment, then they're never going to get connected. So.
Okay, I'm going to admit that professional development for nurses in the 0 to 8 population is very, very limited. It is in our RN instruction. It is in our credentialing. But when you get a nurse 10 years out of that, I could not tell you if they have had up-to-date professional development along that. We work on special ed assessments, and in our district right now, we are really focusing in on special ed assessments and how to do them. And out of that, there will be some assessment tools that we'll be able to give them, but there isn't really a lot out there. We can go through the national organization and the state organizations, but it really is limited.
Similar in school psychology, and yet it's probably not as available because there aren't as many people working with the 0 to 8, but it's there, and it's growing. That's the good news, but we still need more.
Kathleen Halverson, California Department of Education. There's talk about the IEP process and not understanding it, and I was just wondering, there's no mention of 504 plans. Just was wondering what kind of information or training that you get on 504 plans. And then Dr. Coker, as far as, and this was, I was a school counselor, but many moons ago, I don't even know if they do this anymore. But I'm just wondering about ADHD screens. Many times the school said, oh, just take this to your doctor and then we could tell if the child's ADHD. And my concern was always, well, what else were you checking for? Did you check and see if the child was sleep deprived? Many other things that a child can appear to be ADHD, but could be something else.
Right.
And as a pediatrician, you would be the one to be screening for that.
Yeah. Yep. So I can start with the ADHD question. I'll just touch on that IEP. Yes, I think the IEP we do need a lot more information on. And, I think conceptually, pediatricians know, at least in my area, how to help parents get the IEP, what it does, what it means. But the process for parents, I think, is very arduous, very difficult, and so helping them through that process is helpful. As far as 504 goes, my only experience is through our social worker, and actually not too long ago we had a family that she recommended that for, so that's my breadth of my experience with that. ADHD, so the assessment for ADHD is broad. It's not, can't just use the Vanderbilt, or that's the like a screening questionnaire that the parent will answer questions, what happens at home, about the behavior at home, and then usually the teacher will fill out a screening questionnaire about what happens at school. And based on that, it helps to make the diagnosis of ADHD. But as you've mentioned, there's much broader possible diagnoses for symptoms that could look ADHD-like. Not everything that looks like ADHD is ADHD. So it's, it's part of, it's in the guidelines, it's part of what we're trained to do, to look for, to ask about other exposures, to think about sleep apnea. A lot of these things can maybe make a child who has some attention problems, make it to the point where they're having functional problems at school because of attention. And if we could just fix a couple of these things, it might make a difference. Some kids, not every kid who has, ADHD or inattentiveness or impulse control is going to have functional difficulties because of that. And they need to have functional difficulties in order to have a diagnosis of ADHD. So you can take a child who, say, has a little bit of inattention problems, but is functionally okay, and then, there's a problem at home, and so they don't get sleep at night, and then all of a sudden they look like a kid who has ADHD with functional problems. So it's important for the pediatrician or the family physician or the nurse practitioner to do a full assessment. I think from the education standpoint, if the teacher feels like, maybe this is not, that they feel like there's something else going on, I think it's fine to go ahead and give, the time is a big issue, but if you have some kind of relationship with the place that most of you, there's a clinic that's close by where a lot of your kids are going, get a relationship with that physician and say, I noticed a few of these kids are coming in with we're filling out the forms, but a couple of the teachers are concerned that, there's some other things going on. And so just getting an understanding, or even just understanding of what kind of questions they're asking before they're making the diagnosis of ADHD. Or maybe the teachers are noticing that there's other problems, there's family problems that aren't being addressed. So, not every clinician is just, there's a range of ability, there's a range of experience with ADHD. Some kids maybe need to be referred for a mental health clinic for an ADHD diagnosis if the primary care clinician is not comfortable making that diagnosis. I hope that answers your question.
No, I think Lisa and Melinda might have a perspective from the school side on that whole issue that you might want to share.
Well, I can speak to the 504 part of it particularly. In our district, remember, we've got 32,000 kids. Last time I heard we had about 900 kids on 504s. About half of those are for health, and the majority of those on health are for ADHD. We do have 504 accommodations, particularly if a child does not qualify for special education. When I spoke earlier, I talked about, well, they're kids with severe problems, they don't qualify for special ed, so they're off the radar. Well, they're not off the 504 radar, but they're off the data collection radar around IEPs. The 504 accommodations, when you have a child, and I'll use the example again of a child with spina bifida who has to be catheterized at school, do urinary catheterization once or twice a day. That child, if the child has a 504 accommodation, we can't bill Medi-Cal for the services, so we get no reimbursement at all. If the child is on an IEP, we can bill Medi-Cal if the child has Medi-Cal, and the district has a chance of recouping some of the nursing time spent performing the catheterizations at school. So in that way, I would rather the kid be on an IEP so that we can bill for services. Some of these kids we are spending 3 to 4 hours a day providing health services for, and we're not able to recoup any of the cost through Medi-Cal.
Yeah, I think 504 is one of the more inconsistently applied laws that we have. That's what I see, and I think definitely the reason that one of them is, yeah, it's not funded, and I also think there's just so much misunderstanding about it.
Good. Looks like we have time for maybe one more question if someone has one. Andrew, Albert.
Hi, Albert Watt from the National Governors Association in DC. So your responses to the question about exposure kind of started to get to this. I'm wondering if you have a thought about, of all the early care and education programs that serve 0 to 8, child care, pre-K, Head Start, public school systems, is there anything that you think those the educators or the professionals who work in those programs can do better to make your job easier in terms of the clients that you serve? Like, is there something they can be better trained on, or even at just systems level, things that can be improved in those programs that would help what you do better? Does that make sense?
I can start with what we do with our teachers of, it comes down to, we have a motto that's be engaged, be intentional, and be connected. And that really stems from, we have to start with building the relationship with the child and getting to know the child and giving them time to settle into the typical environment after having moved many times. But the teachers have the tools to be able to do the observations and start to observe really what's not so normal maybe, and then they also have strategies to be able to, we say there's a need behind every behavior, so they work through a process of trying to kind of go down a checklist, whether it's hunger, food depravity, or maybe they didn't sleep well that night because there were 6 people in their room. I mean, just kind of going through these different series, and then we do the assessment. So I just think as many tools as early childhood educators can have in their belts that work with children that are disadvantaged or experiencing trauma or homelessness, it's just imperative that they understand that they can be attuned to that and know how to kind of work through the processes of that. I don't know if that answered your question or not, but.
I'll echo something that was said several times earlier today, and that's just knowledge about the effects of poverty. Yeah. I think there are a lot of misunderstandings, and so I think that would be helpful. Yes. to add to what you already said.
Yeah. And I would like more education on what the specialists in the schools can provide. What does a school nurse do? What does a psychologist do? A clinical social worker? So that they're not trying to take on the world without assistance.
For me, I think as far as starting with schools, there are lots of times when parents will come in and we ask about school at every school age visit, and children will be having, there's school failure, maybe there's some inattention problems. A lot of times there's bullying issues that's making the child depressed, and they're getting some, maybe they've taken avenues at the school to get those things handled, but there are things that we can do on the pediatric side that may be helpful if those services aren't available at the school. So one option is sending kids for mental health services. If it's not, I know at LAUSD, the school psychologists really, they're not in that capacity based on funding and availability. And even though we've talked about how hard it is to get mental health, I mean, we can send patients to mental health clinics for therapy. So those things, I think, would be, that communication would be helpful. And also for things like school failure, or just not even when they're failing yet, but they're not sort of doing as well as expected. A lot of times the parents will say, what kind of grades are your kids, the child getting? And they'll say, not so great. And then that's kind of leave it at that. And if you don't explore it, they feel like, well, that's just the way it is. But some of those kids we can send to a developmental pediatrician. And even if they don't, they're too old to qualify for regional center or for the other services for delay or developmental disabilities, they may not really get anything at this point out of an IEP, but that doesn't mean they can't be assessed by a professional. So there are definitely, I think, things that we can work with the teachers at schools around. And it's just, we only see the kids sometimes. After 3, we see them once a year. And so we have to sort of get everything. And usually it's in the beginning of the year before the problems happen. And then we hear about it sort of much later, either the next year, oh, last year was terrible because all these things happened. So, I think if you have a clinician that's close to you, location-wise, and you can build a relationship with them, they can be of good use.
Gisela, would you like to make a final comment?
Yeah. I think what would help is for providers to have resources available that they don't have to be the experts on everything, because no one is. And that's why we have each other, to help each other out. But I think one really important component is really hand-holding our families and our children. There's been times where I've seen, for example, in the school portion, where the child has an IEP for autism, yet does not have regional center services. And this child is having continued behavioral issues, continued bigger and worse problems at home because the issues are not being resolved at home. And many times it could have taken someone to do more hand-holding and really help them call and make that appointment and help them say, these are the issues that are going on. And I'm not going to say that it doesn't happen all the time. And I've had several clients where the parent can't sit with me for 5 minutes because they have to run out and chase the child because they're going to go into traffic. And and I'm thinking to myself, they've had an IEP for 2 years and they don't have regional center. Why is that? And when they call, they're having another difficulty because of the language barrier, because they don't know how to communicate effectively. So I think really is helping them, let's call together and let's see what we can do together. And if I can't help you, let me link you to an IEP attorney, or let's go back to your psychologist and let's get a copy of the evaluations and let's, fax this over to the regional center. So I think that's something that, needs to happen. Yeah.
Okay. Well, thank you all for sharing your expertise and your perspectives today and for giving us your time. It's greatly appreciated. So everybody join in thanking you. Okay, so that's a wrap, huh?
That's a wrap. And cut.